So now we're going to discuss some of the drugs that can be used to uh, modulate some of this cholinergic activity. Here's a nice little summary chart of the drug classes and the clinical uses. Muscarinic agonists, typically we see them used in diseases of the GI or the GU system, as well as topically for glaucoma. The muscarinic antagonists, we see them used in the eye exam. We can also see them used systemically for the reversal of bradycardia, for the treatment of asthma or COPD. The acetylcholinesterase inhibitors have been used and are used in myasthenia gravis, and they've also been started to been kind of expanded for Alzheimer's disease, and so we'll talk about this in the brain behavior and cognition block. They're called nootropics, so they're memory enhancers. Sometimes I feel like I should take one. There are nicotinic agonists, which are used for smoking, so that's nicotine, as well as anti-smoking. And so these would be the drugs that are partial agonists. And so we'll talk about that again in drugs of addiction. And then there are nicotinic antagonists that are essentially used in poisons, surgery, anesthesia, and then they can be subdivided into whether or not if they depolarize or if they're non-depolarizing. So some of these we will come back to in more detail, but this is just kind of an overview. Here you're looking at kind of the interplay between muscarinic and nicotinic receptors, which both have affinity for acetylcholine. I can't stress that enough. A lot of students sometimes forget that. And so there are ways in which you can increase the acetylcholine concentrations. You can do it directly by supplying acetylcholine. There are drugs that look like acetylcholine. These would be the direct-acting drugs that are agonists of either or both muscarinic and nicotinic receptors. There are drugs that are indirect-acting agonists, and so these are drugs that inhibit the degradation of acetylcholine by inhibiting acetylcholinesterase. And so there are some of the effects that we discussed in terms of the heart and smooth muscle, as well as the glands that are governed by acetylcholine stimulation. And then we're really not going to talk about the ganglionic cells. We're really going to focus on the neuromuscular end plate. And so the therapeutic approaches include basically drugs that mimic acetylcholine effects. And so the drug design, so the chemistry, is going to dictate whether or not the drug is specific for nicotine or muscarinic receptors. And so drugs that very closely resemble acetylcholine would obviously bind to both of those receptors. And so from a pharmacologic standpoint, we really have spent a lot of time looking at the chemistry to differentiate, a nicotinic effect versus a muscarinic effect. Now, the indirect acting agonists don't actually involve anything at the receptor level. They basically just inhibit the degradation of the acetylcholine by inhibiting the activity of acetylcholinesterase. And of course, then antagonists would bind to the specific receptor and then compete with acetylcholine for that activity. So let's focus on the muscarinic receptor antagonists. And so typically, if you ever look at these pharmacology lectures in detail, we always start with the agonists first and then the antagonists. Today's lecture, we're going to do the blockers, the antagonists first, and you'll see why. And so there's only two drugs that are kind of important for this lecture because it's an introduction. I want to go to the prototype, which was atropine. And so atropine was essentially pulled out of a whole bunch of plants that are members of the nightshade family, Solanaceae, which is a whole bunch of plants like mandrakes, jimson weed, and so forth, belladonna, some of these other ones. And so these are very poisonous plants, but they all have kind of the same activity, and so this is a good place to start. And so atropine will bind to any and all muscarinic receptors, 1 through 5, and compete with acetylcholine at that receptor site. And so from a systemic or from a physiologic standpoint, atropine is going to oppose the activity of the vagus nerve. Okay, and so from a heart perspective, it's going to allow for an increased firing of the SA node. We're going to see increased conduction movement to the AV node. We're going to see a reduction in bronchial secretions. Atropine can reverse bradycardia, so it'll increase heart rate. It'll dilate the pupils, and actually that's where the the use of this drug in terms of topical administration into the eyes became popular in the Renaissance. Belladonna is Italian for pretty lady or pretty woman. And so women of upper middle class used to dilate their eyes with atropine drops, and to make them more attractive. And so there's historical precedence for this drug. And even though it does have activity for all the muscarinic receptors, it has little CNS effect. So very little of the drug gets into the CNS compartment at normal doses. At poisonous doses or toxic doses, that can be a little different. Atropine itself has a relatively short half-life, barely 2 hours. But when you topically administer it into the eye, and we'll talk about atropine in terms of the eye exam later, the effect lasts more than 72 hours, depending on the formulation of atropine that's used. Of course, if you've ever had your eyes dilated, you know that effect doesn't persist for 72 hours. It's obviously a weakened version, low-dose version of atropine. And so the effects of atropine can be kind of reversed by large amounts of acetylcholine, because then a competition can ensue at the receptor site. But atropine can also be reversed by supplying an acetylcholinesterase inhibitor, okay, which would be an indirect acting agonist. And so these are the effects of atropine in relation to the dose, okay? And as you can see, as the dose gets increased, some of the effects of atropine administration become more and more undesirable. And so you can see at doses greater than 10 milligrams, hallucinations, coma, so these are CNS effects. And so obviously there is a CNS component only at at high doses. But look at 2 milligrams, and so here you can see an increase in heart rate. You can see marked dryness of mouth, dilated pupils, vision problems, altered paralysis, altered peristalsis, at 5 milligrams. And so, the effects of atropine are pretty potent. And so one of the ways that we can kind of remember that is looking at all of these systemic effects in terms of atropine overdose by relating a really cool mnemonic device. And I don't know, do you guys remember the Mad Hatter from Lewis Carroll's book, Alice in Wonderland? So he actually was mad because back in the day, hatters and haberdashers used to use mercury to get these folds and these fedoras. And so they, at some point, ended up delirious. And so the delirium can be seen in kind of high doses of atropine. And so they kind of came up with this. I didn't come up with this, but people over time have come up with this mnemonic, this memory device. Hot as a hair, mad as a hatter, red as a beet, dry as a bone, to kind of remember what atropine does in higher doses. And so, hot as a hair stands, is there to remind you that you see an increase in temperature, a reduction in the ability to sweat. Mad as a hatter comes from confusion or delirium. Red as a beet, see flushed face, tachycardia. Dry as a bone, reduced secretions. Patient becomes thirsty because of this dry mouth as well. And the one thing that's not on this cartoon that I stole from Pinterest is blind as a bat. So here's a blind bat or a blind bat, and that's basically coming from dilated pupils. Okay, and so this is a great kind of memory device to remember what atropine does. Another drug that's in this category is scopolamine, and it binds to the muscarinic receptors, and it's going to compete with acetylcholine. It's got a long history. It used to be used back in the day to treat cocaine and heroin. We don't use that anymore for that. Scopolamine is Dramamine, okay, and so it's applied as a patch, and it's used to alleviate or to treat motion sickness. There are some CNS effects, drowsiness or fatigue, and then some patients experience dry mouth, but the vast majority of this drug is really for motion sickness. And this is kind of a nice overview of some of the clinical indications for all the muscarinic antagonists. Okay, and so we'll stop here.